Welcome back to Radiology Advances podcast.
Today we're tackling a really persistent headache in breast imaging. I'm talking about the high false positive rates you see with diagnostic ultrasound, especially when you're trying to figure out what an ambiguous mass really is.
The paper is titled Generalized Contrast to Noise Ratio Applied to Short Lag Spatial Coherence. Ultrasound differentiates breast cysts from solid masses.
It was published by Drs. Sharma, Oluyemi, Ladiju Bell, and colleagues from Johns Hopkins University in Maryland, United States.
So our mission today is to figure out how combining this advanced imaging technique, it's called short lag spatial coherence, or SLSC, with an objective metric, generalized contrast to noise ratio, or GCNR, can improve our diagnostic certainty. Here's where it gets really interesting, because to understand this, we have to think beyond what we normally do. Typically, we use conventional B-mode imaging, which is all about the amplitude of the echoes coming back.
And we also use tissue harmonic imaging, THI, to try and clean up that signal and reduce the clutter.
But thigh has a major weakness, which the paper points out.
It does. Its improvement is much, much better in fatty breast tissue. For women with dense breasts who are already a higher risk, harder to screen group, THI just doesn't help as much.
Which brings us to short lag spatial coherence imaging, SLSC. So what is this doing differently under the hood? Okay, let's pause on coherence. Acoustic clutter is random signal noise, disorganized.
It doesn't look at how strong the echo is, the amplitude. It looks at the organization of the echoes. It measures the local spatial coherence of the sound waves coming back. Think of it like a blizzard of signal noise. It blurs everything. But coherence is a measure of how orderly those echoes are. Fluid, like inside a cyst, is very uniform, so it produces highly organized, predictable, coherent echoes.
Whereas solid tissue is more chaotic, so the echoes are more disorganized.
Precisely. So SLSC imaging basically filters out that blizzard of random noise and makes the difference between the orderly fluid and the disorderly solid tissue much, much clearer, especially in that dense tissue we were talking about.
So we have a better image. But the problem of subjective interpretation remains. Why do we need this other piece, the GCNR? Why not just have the radiologist look at the better SLSC image?
Because even with a better image, the human eye is still subjective. Quantification is what drives standardization. The GCNR is an objective number, a ratio that you apply to that SLSC image.
And it gives you a clear classification.
A clear classification. A GCNR value close to 1 means high coherence, so it's fluid, it's a cyst. A value closer to 0 means low coherence, it's solid. And the key is that this difference, the separation, is just dramatically amplified when you calculate it on the SLSC image versus the old B-mode image.
Okay, so let's get into the study design because the results are only as good as the methodology. This wasn't just a look back at old charts.
Oh, not at all. This was a secondary analysis of a big prospective study, the auspicious study. They enrolled women who were already scheduled for ultrasound-guided procedures or follow-ups.
And for the actual test of this metric, they focused on a specific subset of patients.
Right, the key analysis was on 112 masses, and that group was made up of 16 complicated cysts and 96 solid masses. And within those solid masses, you had 71 benign and 25 malignant, so it was a real-world mix.
The ground truth, the reference standard was solid. Simple cyst confirmed on B mode. Complicated cyst confirmed by successful aspiration.
And all the solid masses were confirmed by pathology, core needle biopsy, or surgical excision. There was no guesswork there.
And to test this, they had 6 board-certified breast radiologists with a huge range of experience go through this blinded assessment.
Yeah, from 5 to 27 years post-residency, they wanted to capture that real-world variability.
So task 1 was just the status quo, right?
Exactly. Here are the B-mode images. Make the call on content, give it a BI-RADS to score, standard of care.
Then for task 2, they got to see both the B mode and the new cleaner SLSC image.
To see if just having a better picture was enough to help.
And finally, task 3. This is where the GCNR comes in.
This is the real test. They had the radiologists draw a region of interest, an ROI, on both the B-mode and SLSC images, and then the software calculated that objective GCNR value based on that ROI.
And that calculation was standardized, so it didn't matter what settings the radiologist preferred.
Correct. The parameters for the GCNR calculation were fixed. This removes the reader's judgment from the final number.
Which brings us to the results. And this is where the numbers just speak for themselves. The diagnostic accuracy measured by the area under the curve, the AUC was, well, it was a huge leap.
Let's start with the baseline, the B mode only. The mean AUC was just 0.67. Some readers were down at 0.54, basically guessing. Just confirms how tough this problem is with our current tools.
Okay, but then they apply the objective GCNR to the SLSE images. What was the number?
The mean AUC shot up to 0.96, a statistically significant jump for every single radiologist. They basically took a highly variable, low accuracy task and turned it into a near perfect classification system.
So what did that mean clinically? They set a threshold for the GCNR at 0.76. Anything above that was called a cyst. What was the payoff?
Well, they looked at the 16 complicated cysts that were initially called suspicious BIRADs, 3 or 4, the ones heading for a procedure. Using that 0.76 GCNR threshold, 8 of them, or one half, were correctly re-identified as simple fluid. That's 8 patients who could have avoided an unnecessary procedure.
And the big safety question, did it misclassify any cancers as benign cysts?
That's the most important question, and the answer is no. At that threshold, 0 of the 25 malignant masses were misclassified. It had high accuracy and high safety.
Now, what about the other major issue of inter-reader agreement?
Right, so they used the Fleiss's kappa statistic for that. For the subjective B-mode readings, agreement was only fair, a kappa of 0.4.
And here's what I found fascinating. Even when they gave them the better SLSC image to look at, the agreement barely budged. It went up to 0.41.
It's a critical point. A better picture isn't enough. The interpretation is still subjective, but when they use the objective GCNR metric with that 0.76 threshold, it improves significantly to a moderate agreement, kappa of 0.59.
But what does this all mean? What are the big implications?
To start, for any center dealing with a high volume of screenings, especially for women with dense breasts, this could slash the false positive rate.
Which means using resources better, fewer unnecessary appointments, fewer procedures, and less patient anxiety.
It really makes the case for standardization. With subjective B-mode readings, individual radiologist performance varied widely. AUCs ranged from 0.54 to 0.76, but with GCNR applied to SLSC, that variability nearly disappeared. The range tightened to 0.93 to 0.98.
But this isn't rolling out into every clinic tomorrow. What are the limitations, the barriers to getting this adopted?
Well, the biggest one is that it's still prototype technology. The SLSC code, the software, it's not a commercial product you can just go buy. And the study was done at one academic center, Johns Hopkins, using one specific type of scanner, so we still need to see if it's generalizable.
And there's a workflow issue too, right? The manual part.
Correct. Having the radiologist manually draw the ROI takes time. That's a real barrier in a busy clinic. Plus, there are some technical limits. It doesn't work well for very superficial masses less than 5 millimeters deep.
Okay, so to sum it up, this study shows that applying an objective metric, GCNR, to this advanced ultrasound technique, SLSC, give you a massive boost in diagnostic accuracy. We're talking an AUC of 0.96 and much better agreement between doctors for these really tricky cases.
It basically provides a way to move from a subjective interpretation to a reliable, quantified answer based on the physics of the tissue itself. But they noted something else. If they lowered that threshold just a bit, down to 0.73, they could get even better consistency, substantial agreement, a kappa of 0.70.
And that leads us to our final provocative thought for you to take away. The researchers chose that 0.76 threshold because it was perfectly safe, it missed 0 cancers, and it gave moderate agreement between doctors. But there's a trade-off, a big one. At that more consistent 0.73 threshold, you start to introduce risk. The model predicted that 1 to 3 malignant masses could be misclassified as benign per radiologist.
So it raises this really critical question as we move into an era of more automated tools. How much diagnostic certainty are we willing to trade for better inter-reader consistency, and what threshold of missed malignancy is acceptable when we implement these new objective metrics?
It's the ultimate accuracy versus risk dilemma, and it's a profound challenge we'll be facing in our practices. We're coming to a close of today's Radiology Advances podcast. Thanks to Drs. Sharma, Oluyemi, Ladiju Bell, and colleagues for their work published in Radiology Advances. If you found this episode informative or have any other feedback, please rate, review, and subscribe. It helps more people discover the podcast and supports the broader conversation around innovation in imaging. You can read the full article and explore more great content on the journal website. This episode was generated with the help of AI, but all content was reviewed and verified by editor Dr. Nelson Gill from Massachusetts General Hospital for Accuracy. Thanks for joining us.